Good evening, everyone, and thank you for joining us today. My name is Jared Young, and I'm with Brightstar Therapeutics. We're excited to welcome you to this special virtual demonstration of the BrightMem anterior keratoplasty, an innovative approach designed to support epithelial healing and corneal surface restoration in patients with complex ocular surface disease. At Brightstar, our mission is to advance eye care through innovative, science-driven solutions that meet real clinical needs. BrightMem represents a new frontier in allograft design, offering surgeons a durable acellular scaffold of Descemet's membrane that can be used in a wide range of challenging cases, including persistent epithelial defects, limbal stem cell deficiency, and more. Today, you'll have the opportunity to observe a live demonstration of the BrightMem procedure by Dr. Joseph Tauber, our Chief Medical Officer and one of the earliest adopters of this technique. Dr. Tauber offers a wealth of experience in corneal and ocular surface disease, and we're thrilled to have him walk you through his approach, pearls, and real-world outcomes. As this is a live demonstration, you'll be seeing the procedure through the microscope tonight. If you have any questions, please use the Q&A button at the bottom of your screen to submit them. Once we're done with the demonstration, I'll read off the questions for Dr. Tauber to answer. Following the Q&A, we will also send you information on how you can request BrightMem tissue, register as a provider, and connect with our team for further support. Thank you again for being here. We hope you find today's session informative and valuable as you consider incorporating BrightMem into your surgical toolkit. Now, please let me introduce our host, Dr. Joe Tauber. Dr. Tauber is a graduate of Harvard Medical School and completed fellowship training in cornea and ocular immunology at the Mass Eye and Ear Infirmary. He is an internationally recognized voice on ocular surface disease and dry eye treatment and has practiced for 35 years in the field of complex corneal disease. His work has made him a key opinion leader in his field, having served as a principal investigator in over 150 research studies of high-risk corneal transplantation, inflammation, infectious diseases, and numerous studies related to dry eye syndrome. Dr. Tauber has served on many scientific advisory boards for industry who value his insights on protocol design and new product development. He has recently transitioned to become CMO for Brightstar Therapeutics and also for Vital Tears. Dr. Tauber, welcome.
Good evening, everyone. We just got to solve a tiny little audiovisual problem with advancing the slides, but thank you all for taking time this evening to join us to talk a bit about the BrightMem and Brightstar and to see how it's actually performed. Hopefully you all learned a little bit about this from either our website, from events we've had at Academy or ASCRS, but this evening I'm going to talk to you a bit about the scientific background for BrightMem, review the clinical data that we've been able to collect. I'm not going to show you a procedure video. You're going to see a live procedure. That's the demonstration, and we'll leave plenty of time for Q&A so we can answer any questions that may be on your mind. BrightMem is a novel corneal allograft made from Descemet's membrane, which creates a new foundation for the ocular surface, a substrate capable of supporting native limbal epithelial stem cells. This represents a unique treatment for patients with impaired corneal healing of a variety of reasons. BrightMem is made from donor corneal tissue, classified by FDA as minimally manipulated, and is available through Brightstar and our distribution partners. The procedure, which we call anterior keratoplasty or BrightMem anterior keratoplasty, is coded under CPT 65710 as anterior keratoplasty, and the tissue is reimbursed at invoice cost using V2785. BrightMem was designed specifically for patients with partial limbal stem cell deficiency, but as corneal surgeons are known to do, it's been used in a wide variety of non-healing corneal indications. We're still early in our experience exploring the utility of BrightMem in a range of indications, but we see substantial and broad promise. We have surgeons doing pediatric cases, including at least one 3-year-old with sclerocornea and E. bullosa, who healed completely at 1 week, which is a rather remarkable outcome. I'm not going to go through in detail this algorithm for managing limbal stem cell deficiency and non-healing defects, But as we all know, there remains a need for more effective solutions. I want to highlight two things, numbers 5 and 7 on this slide, as strategies for which we still need better options. I refer to optimizing the underlying corneal substrate and rehabilitating the existing limbal stem cell population prior to replacing stem cells. So this is not a procedure really designed for total stem cell loss, but partial stem cell loss. I do want to highlight a few things from our basic research that led to the commercial development of this product. That work, the discovery, was by Dr. Josh Ho at the University of Minnesota, and he found a number of things that were really rather fascinating. We all know that Descemet's membrane is optically clear and resistant to collagenase digestion. We know this from watching desmetaseals persist for much longer than one would think just to look at it. What Dr. Ho discovered is that the anterior or fetal banded layer of Descemet's membrane expresses certain limbal basement membrane specific proteins, different from what is expressed by the central basement membrane of the cornea. Descemet's membrane can serve as a long-term substrate for the corneal epithelium, supporting the proliferation of limbal stem cell and progenitor cells. So, how does Brightmem, a Descemet's allograft, help these patients? I mentioned it's the anterior surface of Descemet's that has these special proliferative proteins in the membrane, and I referred to vitronectin and Spark BM40. Again, these are found in the limbal basement membrane, but not in the central corneal basement membrane, and these are essential for maintaining the stemness or the proliferative potential of limbal stem cells as they grow across. In normal healing, limbal epithelial cells begin to differentiate as soon as they begin to migrate over the surface, and that continues as they stratify to a multi-layered epithelium. This is a confocal microscopy image of limbal cells grown on a Brightmem. While they organize themselves in stratified layers, just as they would in the normal cornea, you can see the bottom layer of cells touching the Brightmem continues to express stem cell markers P63 and ABCG2, shown in green. As the cells stratify, you see the superficial layers at the top express markers for mature epithelium, shown in red. The key point is that the Brightmem helps maintain a population of proliferative stem cells or transient amplifying cells at the basal layers. Maintaining this reservoir, if you will, of stem cells is how Brightmem may promote ongoing epithelial regeneration. Here is another confocal image showing the expression of stem cell markers, again in green, and you see that these markers stop rather abruptly when the cells grow beyond the edge of a Brightmem. In this slide, a limbal explant biopsy was allowed to grow to confluence across the Descemet's membrane, sitting on tissue culture plastic. You can see the sharp demarcation in stem cell biomarker expression in the cells on the Descemet's membrane, that's below the dotted line, and cells that grew off the Descemet's membrane, and that's above the line. Rather striking, really. This study demonstrated that Descemet's membrane significantly protects stroma from enzymatic digestion compared to amniotic membrane and control samples in a study where they were exposed to collagenase A. After 24 hours, corneas treated with an amniotic membrane and controls both thinned dramatically to nearly half their original thickness, while the Descemet's treated corneas experienced minimal thickening, just a little over 9%. For Brightmem to protect stroma, it has to be present. So we tested how well it persists. Here again, we exposed both Brightmem and amnion to collagenase. In the images at the top, amniotic membrane degrades within 30 minutes. At the bottom, you can see that Brightmem persists beyond 24 hours. The tissue does scroll after some hours, but it does not dissolve. We are certainly early in gathering clinical data on the results with the Brightmem allograft, as at the time of this recording, approximately 60 procedures. Sorry, I don't know why that's a recorded audio. I'm not sure how we can stop that. Let's go to the next slide. That's a first audio visual
have been
Snap in
done,
for me.
as will not
Let's do resume, and then just go to the next slide.
surprise you.
All right, hopefully I won't be talking anymore. Since BrightMem was launched nationally last year, the number of BMAC procedures has grown significantly. There's now been over 250 procedures performed by over 90 surgeons. Most of these procedures have been done on patients with limbal stem cell deficiency and persistent epithelial defects. There have been no serious tissue-related adverse reactions, and BrightStar has not had any physicians have issues getting reimbursed for the procedure. On the bottom left, you see kind of a distribution of the most popular indications for which the procedure has been done. Here is an interim outcome data analysis of 110 cases for which we could gather data. In this population, who failed to heal with 1 or 2 amnions, we achieved 92% healing at a mean of 34.5 days. I do want to point out, because we recommend leaving the lens in place for 30 days, we wouldn't detect healing before that date, but we believe many patients have healed faster than the 30 days. We've also looked at the durability of this healing and found that 98% of our cases that have 6 months of follow-up have healed, and that includes 46 cases at the time of this analysis. We're actively working to refresh this data now. Dr. Ho gave an update on his clinical trial at the World Cornea Conference in the spring. In his 17-eye series, BMAC showed promising outcomes. A few I want to highlight. Central staining grade significantly improved from 3.2 to 2.2. Mean acuity improved from a logMAR of 1.51 to 1.02, which correlates to Snellens of 20/650 up to 20/210. And of course, we all know that analytics will not achieve a full 20/20 vision. 2200 may be the best that many of these patients ever achieved. And very strikingly, superficial neovascularization recurred in only one case, meaning 5.8%. I'm sure all of us, or all the corneal surgeons on the call, have dealt with cases with superficial neovascularization, and that always recurs. So this is really something rather striking. There were also no persistent epithelial defects post-op. So as sort of a summary view, this is the basic procedure. The BrightMem allograft is supplied as a stained graft on a typical donor corneal button. The surgeon performs a superficial keratectomy to the diameter needed, places the trephine graft on the bare stroma, dries fluid from the edges for several minutes before removing the anterior stromal button. The S-stamped crystal clear allograft is shown at the bottom left in place and dries for several minutes before a small amount of fibrin glue is applied and then a bandage contact lens. Depending on the complexity of the superficial keratectomy, the entire procedure can be as brief as 15 or 20 minutes, and all of my cases are done under topical anesthesia. So in summary, BrightMem represents a new avenue of treatment for impaired corneal healing. Its unique mechanism of action is distinct from all existing therapies and could potentially synergize with them to enhance outcomes. By that I mean if you have a patient with total or near total stem cell loss, these can be combined with SLET or CLAW or other procedures that add stem cells to the surface. Okay, and then we're going to shift gears and change our camera to the microscope and let you see how we do this. And I'm going to speak as though I were standing next to the surgeon in the OR and try to share as many tips as I can. Typically, we will share a tips and tricks, let's turn that on, a tips and tricks document with all surgeons before we start because it's hard to remember everything that I can say in a phone call. All right, so you receive the cornea button that looks like any other, as we said. This has been stripped like a DMAC, if you will. It's been stained with Vision Blue. It's been stamped with a reverse S stamp, which means when you put it down on the surface properly oriented, you will see a properly oriented S. One thing I stress to surgeons, and I'm certainly guilty of this myself, I don't inspect corneas very, very closely when I'm doing, for example, penetrating keratoplasty. In this case, you do, because this has been stripped and then laid back down. So let me just highlight what we're seeing. You see two lines on the scleral edge. that's where the hinge is. So the DMEC, if you will, has been stripped from not where the S is, but the other side, pulled back to the lines, which are the hinge, put back down. So that's the orientation. Ideally, the area that you tree fine includes the S. In this case, the tissue is sitting very nicely, so I don't have to do anything to straighten it. There are some tips to do that. So I will just let the fluid drain away, and I'm going to transfer my tissue to a Teflon block. We do recommend a vacuum Teflon block because we don't want this to slide as we're doing our procedure. I will reset that focus for you in just a moment. Sorry, we'll be focused here very briefly. So this is under vacuum right now. For this demonstration, this is a 7 mm. Depending on your specific case, maybe a 7 is fine. I've used as large as an 8.5. The limiting factor is where that hinge is located. Because if you were to tree fine beyond the hinge, you would still have some residual attachment. Oh, sorry, I do want to show you one more thing here, so I'm gonna have to hold this up. So after you've tree fined, we get rid of the peripheral skirt. Okay, in this case, I'm not quite sure where that is. Interesting, yeah, may have slid off a little bit. So I'm going to use a Peyton spatula. I may have to go off camera here for a second because I'm going to wind up putting it back on our globe, but I'm just going to put the Peyton underneath this button. And I try to transfer this as best I can to the center of the cornea. If you don't exactly get center at this point, it's okay to move it around. Now remember that you have a Descemet's membrane that is not attached, sitting at the bottom. So in a sense, you want to wait a bit, but you could pull that away and you'd have Descemet's sitting on the surface. In fact, the visibility of the S tells me that there's already some separation. So your first step is to spend 1 to 2 minutes drying around the edges to wick away fluid. And we do this without moving the button. So it's okay to move the button when you first put it down if you've gotten way off. I should say your target area where you want the membrane to stay at the end of the case, you need to have a 0.5 mm margin between the end of the membrane and the edges of your superficial keratectomy. Forgive me, I did do the superficial keratectomy before we went on camera, but you can use the Peyton spatula, you can use this scalpel edge, you can use whatever you're used to. So in a cadaverized situation, I don't think I need to wait a whole 2 minutes because we obviously don't have functioning endothelium that's helping to pull that membrane on, but that's what would happen in a real case. So you could, at this point, simply engage the stroma with a toothed forceps and just obliquely pull that away. I'm just going to demonstrate what we call the nudge technique, which I actually favor, and that's to use a blunt instrument, not to engage the tissue, but just to push it. So I can see more clearly that I definitely have separation between the stroma and the underlying membrane. And once I've done that, then I can get rid of my stromal piece. All right, this is where everyone panics. Not everyone, or some people panic and says, oh no, it's curled up. It's always curled up. You'll never get a situation when you put it down and you have a perfect circle with a properly oriented S. So don't be worried if that's what you see. First thing I like to do is a couple of drops of BSS, because it turns out just the weight of that fluid does a very good job of realigning tissue. Then I like to use the cannula tip. I like a 25 gauge. Dr. Ho actually prefers to use a 30 gauge. I think anywhere from a 25 to a 30 is fine. And as I like to explain to people, and I'm going to speak as I'm doing it, first thing I got to figure out if I have a if I'm upside down or not. And I do that by watching my S. So the tissue could be malconfigured, if you will, in several ways. You could have what I call an overfold. Those are easy because you just flip the edge back out, like I'm doing right here. And I got a proper S again. You could also have an underfold. If you have an underfold, let's say it were right over here, so this S is upside down and under, I like to use the tip of the cannula and just drag the tissue away, like I'm showing here, because an underfold will kind of flip its way out as you do that. We don't have any underfolds here. Let's get that back a little bit to the middle. Good. Now, this is still a little bit blue, and hopefully you can see that part of it well enough. And I mean the entire Descemet's is a bit blue. If you decide when you're looking at it in the viewing chamber, it's not blue enough, you can actually restain it with a little bit of Vision Blue. Just a drop or two, 30 seconds, and then you're good. So once you have this totally flattened out, we go back to the drying around the edges again without touching the button. So again, this is where you want to think, do I have that 0.5 margin from the end of the Brightmem to the edge of epithelium that I've left? The reason for that is if you're lucky enough to get epithelium growing in quickly, you don't want that epithelium getting underneath the Brightmem before you get really good adhesion. All right, so this actually looks pretty good. You're still waiting at this point 2 or 3 minutes just to let this thing adhere. Again, cadaver eye is not going to behave like others. Then you want to try to get rid of any wrinkles that may exist. And I'm not sure the lighting is going to allow you to see it the way I see it. But the technique is using the cannula tip as kind of a squeegee motion. So we put it down and we sort of, I don't have very much adhesion now. So I'm gently just sort of rubbing a bit from the middle to the edges, smoothing out as I go, and I do that in all directions. And this may take several minutes. You can tell I still don't have much adhesion. Let me just show you wrong things. When you try to move the tissue with just a single point, as opposed to the whole line of the cannula, I find you create as many folds as you fix. So I don't like doing that. So again, I've got a big fold there in the middle, a couple of drops of BSS, always very, very helpful. And then I go back to squeegee. Squeegee, again, I'm using the linear part of the end of the cannula. Some people have used a muscle hook. We've tried a LASIK flap roller. I find both of those just a little too large and crude, if you will. And I think this is really the best tool in my hands. And I think many, many surgeons have said the same thing. So I would encourage you to at least start this. So just to say that all again, the sequence is first assume that everything is an overfold. And by that, I mean, try to flip the edges out. If it doesn't behave the way you're expecting, then you may have an underfold, then go to the tissue drag technique. And then you go to the squeegee technique using the cannula tip. But when you're done, you wind up with what you see here, an optically clear circular graft. I've done a lot of messy cases. I've done a lot of K-pros in my time. I find this just elegant. I really get joy out of seeing tissue like this on the eye. And obviously with tissue of this clarity, the patients have quite good acuity on the first couple of days. It's a little bit like a PRK experience in that as the epithelium comes in, the vision may actually degrade a little bit when you have half the surface covered with epithelium and half not. So once you have everything in position, we go back to, as I said before, drawing around the edges of the allograft, this time 2 or 3 minutes. And I'm going to abbreviate that for the purposes of this demonstration. And at that point, it's on there pretty good. You can test it with the cannula tip, and it really won't move at that point. Again, cadaver eye, not going to behave quite the same as it would in a living eye. Let's just see how good this is, though. Yeah, you could see before how much it was moving, And I hope you can see it's really not at this point. Now, when I say squeegee action, what I don't do is go from this point all the way to the other side. I go from the middle out, from the middle out. I reorient, middle out, middle out. So you're doing it in all four directions just to get out wrinkles, which means really fluid or air from underneath the tissue. But at this point, you have a pretty straightened out Descemet's graft sitting on the surface. We recommend a little bit of tissue glue just to seal the edges. So how do we do that? This is not tissue glue, but just intended to show you little tiny drops of component 1. For a while, I was doing 12, 3, 6, and 9. I think you can really, this is viscoelastic, so it behaves a little bit like component 1 of to seal. But we're not gluing the entire graft onto the surface. We're simply going to seal the edges. So I put, in this case, I'll put down 6 pretty tiny drops. Then I'll use my cannula tip to spread them just to cover as much of the circumference as I can. Once you have that 360 coverage, you use component 2, and I'm simulating just with some BSS at this point because component 2 is quite a bit thinner. Add component 2 thin, give it 45 to 60 seconds to polymerize. There's nothing wrong with going longer. I just read an article today that people think polymerization time, for whatever reason, was to seal. It seems to be going slower than anyone is used to. And then you finish the case by placing a flat fitting contact lens. I like a Night and Day 8.8. You need a lens that doesn't leave a bubble. Of course, we've got a cadaver eye here, so I don't even know how this is going to behave for us. Some people use a contour, which is just fine. If you do a contour, it should be in the base curve range of 9 or 9.8, not a 7, not even a low 8, because you don't want these bubbles. Bubbles are problems. And yeah, you can finagle a little bit to get rid of a bubble, but I think for this cadaver eye, this lens is really not ideal. Then you're done. That's your case. So again, if your superficial keratectomy was not prolonged, was not vascular, 15, 20 minutes is really enough to do the entire case. Sometimes a superficial keratectomy takes 35 minutes by itself. It's bloody. It is very important, by the way, you need to leave the stromal surface dry and completely cleared. So if you have a little bit of dribbling of heme onto the surface, that's not okay. You need to deal with that either with direct pressure from a Wexel or from a cotton swab, or you can even use some phenylephrine solution like a Pledget to try to get it to close up. I've never had to do cautery. In general, I don't recommend cautery because cautery is far more inflammatory than anything else you're doing in the case. This is a very benign procedure, if you will. It doesn't create much inflammation, and you can see how white this patient's eye. Okay, that's a bad joke. In general, patients leave the room with a very white eye, and we really haven't stimulated very much. Post-operatively, 3 times a day, antibiotic and steroid. I like to recommend 3 times a day Miro 128 solution, not ointment, just to help the endothelium suck that membrane onto the surface. You can stop that at a week. You can taper the steroids over about 2 weeks. And of course, you may have a case that's more inflammatory because of underlying disease, and you may choose to go higher. But again, for the surgery invasion itself, TID is really sufficient. So I think that's all I can really share with you as far as the demonstration. I'm going to turn it back to Jared to moderate through a Q&A session, and hopefully you've got questions.
Joe, do you want to talk about keeping that contact lens on?
Yeah, sorry. So I mentioned the post-operative regimen. Corneal surgeons have any number of bad habits, and I say this as one myself for 35 years. We want to know how things are going. So on day 1 or 3 or 4, you just want to take that contact lens off and see how the surface is. Please don't do that. We had a few people just be a little rougher than they should be and created some wrinkling in a graft by doing that early. It's pretty rare to get healing within a couple days anyway. So we recommend leave the contact lens in place untouched for 30 days. So you do want to get a high decay lens to do that. Again, it does not have to be contour. I've had no issues at all with a night and day, and I'm not aware of anyone who's created any anoxic challenges with the cornea. We've had no postoperative infections related to the surgery. It's been extraordinarily successful.
Well, and Dr. Tauber, I can say just from my own time talking to doctors, at one point I had a doctor say, "You mean I can't touch the BCL either?" No, you can't touch it either. So the patient and the doctor leave it in place for 30 days.
Let me go back one thing on glue. So again, cornea surgeons are a little nuts, right? So I can say use 6 very tiny drops to cover the circumference. And well, some of us kind of have a heavy hand. And we've had 2 instances where people used excessive amounts of glue. Okay, why would that be a problem? Well, the problem is when you put a flat fitting contact lens on, some of that now polymerizing glue comes squishing out underneath the contact. And we had 2 people not really think about what they were doing and said, well, I'll just pull off the excess. And they pulled off more than just the excess. So in case you apply too much and you do get some coming out from the contact, you do want to get rid of it because glue also is inflammatory, different from everything else about the case. Just use a Westcott and trim off everything that's beyond the contact, and then you can peel it away. So try not to yank things.
No, I think that was excellent overall, and I appreciate your time doing this, Dr. Tauber. I especially appreciated that you were able to show how to unfold the tissue. It's not common that happens, but it was a great example of how to get it into the right orientation. So I think that worked out great.
Everyone that I speak to, I counsel to go through those 3 steps. First, assume everything is an overfold and just try to flip the edges out. If it doesn't behave, drag it as though it's an underfold, and then come back and deal with wrinkles.
Exactly. And then also, we encourage everyone to, once they register and have their first case, to do a Zoom call with Dr. Tauber and work through any of those potential questions or issues you have. And we're going to get to a couple of them right now. We do have a few that came in. So one I can answer is, what codes do you use for stem cell deficiency to get this covered? The answer is the ICD-10 code that's recognized for either non-healing corneal defects or limbal stem cell deficiency is H18.899. The descriptor there is other specified disorders of cornea, unspecified eye. You could also use H18.893, 892, 891. Those are each for different eyes, so bilateral, right or left. So those all, Dr. Tauber, do you have any other input on that? But those all do work for.
Absolutely. And this comes from 35 years in practice where, priority number 2 after helping a patient was getting paid for what we were doing. Understand that what we're doing here is an anterior keratoplasty. So any code for which an anterior keratoplasty will be reimbursed is going to work. Everything is a scar. Stem cell deficiency is very obtuse as far as finding the right code. So I think rather than torture yourself to find what code is going to work, call it a scar, code the neovascularization, things like that. We've had no surgeon get stopped on reimbursement. So whatever it is everyone has done, and it's not going through us, so I don't have full information, but no one has had a problem.
And to the doctor who asked that, if you have more questions, feel free to reach out. I'm happy to talk to you directly. We'll send you my information as well as Dr. Tauber's, so we can certainly help out there. Next question was, can BMAC be performed on corneas with heavy NV with fibrosis? What needs to be done, if anything, differently in these cases?
Well, I think the answer is your SK is going to be challenging. But yeah, I mean, people have done, my first case was a pemphigoid suspect. And, it's like peeling off a very, very heavy layer of conjunctiva before you get down to underlying clear cornea, which is, of course, a wonderful experience to find clarity underneath all that. Then you have to stop the bleeding. So that's what I was referring to by your SK may be 5 or 6 minutes, or maybe 35 or 36 minutes, depending on that severity. But absolutely, the same case can be done.
So the next two questions you kind of already answered. One was, how important is the drying time? I think we know that it's important. We want to make sure it adheres.
We there's nothing worse than losing a beautiful graft that you've got applied. So the last thing we want to see is any wrinkling. Let me give you an anecdote from my first case, and I'll cash this in the intro is don't do what I did. So I did a pemphigoid suspect, as I said. Case went great, kind of a tough SK, got the graft on, grabbed the contact. Oh, I don't have enough fornix to get the contacts to fit. Wouldn't stay in there. So I shoved it in anyway, and I did a 50% tarsorrhaphy, and I congratulated myself, and I went home. I see the patient the next day, and darn if that contact hadn't folded itself over in half and was trying to get out the half of the lids that I'd left open. Okay, so I took a second contact in the office, hand trimmed it down to about 8 millimeters. With my left hand, separated the lids as wide as I could. With my right and a jeweler's forceps, I took out the dried contact, took my hand-cut new one, shoved it in, shoved it under the sewn part of the lid, and everything worked fine. Patient healed perfectly. So why am I telling you this embarrassing story? Because the BrightMem didn't move. Once it's on, it's on. So that's why all of our recommendations are get good adhesion. I think more minutes of drying is only going to help you. I think getting 360 coverage with the glue is only going to help you. That's the philosophy that underlies it.
Joe, back to our previous question, just wondering how dry do you need to get the surface before you put the button on? I know that that's been a question for a lot of folks, is how dry is dry enough?
It's hard to answer that one with words. It's all about the adhesion. So heme is bad, right? Heme is bad everywhere. Heme is bad under a DMEC. You don't want it. It's going to do things. So often surgeons will continue with the case even though there's a little bit of dribbling. Tincture of thyme is my favorite medicine to use. I like to press on it with a Wexel or a Q-tip, and there's nothing I haven't been able to get bleeding to stop. Phenylephrine is wonderful as an assist, and I suppose if nothing else worked, I won't tell you you've done something terrible if you use cautery, but I think it's very important to stop anything oozing into the field as you put down the membrane. Not sure I can answer how dry is dry enough. Dry, dry. We take a Wexel spear and just pat it down on the surface.
Until it doesn't move, right?
Until it's dry enough, yes.
Yeah. Next question is, does it work in cases where there's 360 degrees of corneal vascular inaction?
Sorry, what was the word after vascular?
Does it work in cases where there is 360 degrees of corneal vascular inaction?
Vascular inaction. I'm not quite sure what that's referring to, but I'll answer two ways. First of all, let's highlight that all of us are very bad at diagnosing the extent of limbal stem cell loss. No one has made this more clear than Sophie Deng, who points out that the way we diagnose it is just poor. We look for the presence of neovascularization. We look for whorl-like epithelial changes, and those are just not reliable. And she just described many cases she's been referred that look like that, and the patients had absolutely normal stem cells when she did confocal microscopy. So she likes late staining with fluorescein as her best clinical tool if you don't have confocal microscopy available. So that's my preface, is don't be scared about lots of neovascularization that may or may not correlate with how much stem cell loss you have. Will it work in 100% stem cell loss? Corneal surgeons are nuts. I don't know another way to say it. I've got very skilled friends, colleagues who have done this surgery on patients with 100% stem cell loss, surgeons who absolutely should know better, and the case did okay anyway. And I think that really reflects our inability to be precise about saying how much is left. Uh, we kind of chose the idea that the Brightmem works up to 75% loss a bit arbitrarily. There's also been discussion that perhaps if there's 10% remaining stem cell function, that may be enough to repopulate the entire surface. Because you don't just, in the normal healing, as I said before, stem cells start to grow and they start to differentiate immediately. But when they grow over Brightmem, they don't do that. So you get a more regenerative layer covering the entire surface. I like to tell people, the XYZ hypothesis of healing, but on a Brightmem, you may be getting just Z or primarily Z because you've got better, more juvenile, more cells with more regenerative capacity at the basal layers, and it stays like that. So yeah, I think getting close to 100% is not a problem. And certainly the extent of neovascularization is not a problem.
All right, well, the next question I have for you is, this is a little bit of a longer one here. So do you have to have clear underlying stroma? If there is corneal scarring, like from prior bacterial keratitis, with overlying non-healing epithelial defect, can you just remove the epithelium over the scar and use the DM over it, even if the underlying stroma is not smooth? This would be a neurotrophic cornea where PKP would be higher risk and just trying to get epithelium to heal.
So long questions get long answers. There's a lot to unpack there. There are certainly cases, many that have been reported to us, by the way, where there is some, let's just call it haze in the stroma that seems to resolve after a Brightmem. Having said that, no, Brightmem doesn't get rid of stromal haze. Brightmem doesn't solve 100% stem cell loss. You need stem cells for that. If you have an opacity, you need a lamellar keratoplasty, you may need a penetrating keratoplasty. But you're right, that's a more invasive, more risky surgery. And again, we've had a number of surgeons who said, no, I'm going to do a Brightmem first because now I can see inside the eye. I was looking at gray conjunctiva before. I didn't even know what was in there. I didn't know if the patient had a cataract. So you have much better visualization of everything going on inside. Let it heal, let it calm down, and then you can come back with your penetrating procedure later. We have at least one surgeon who's spoken to me at length about this. In many of his high-risk retransplants, he does a Brightmem primarily. So, and I'm mentioning that because if he did a Brightmem, got visualization, said, oh, okay, that scar goes down 70%, I'm going to need to do a PK. You could put a Brightmem back on top of the PK. Here's the challenge. That's an anterior keratoplasty on a penetrating keratoplasty. Now you have two pieces of tissue. That's the problem. Because you can't bill for two pieces of tissue. But is that the right solution for the patient? I think it is. I don't think it would be wrong to do the Brightmem, make your decision about the second procedure and do a PK. And then if it doesn't heal, come back with the BMAC procedure, the LK on top. That would be fine too, and be more safe from the financial point of view for your hospital or surgery center.
I think that's great feedback. Those are all the questions that came in, Dr. Tauber. Is there anything else you want to discuss? I know we had talked earlier about really what are the most important things for a first-time doctor to keep in mind? What are the pearls that you would recommend briefly, and then we'll wrap this up?
I mean, maybe I'm projecting my own fallacies when I speak about things like this, but I'll start at the beginning. You really have to examine that corneal tissue in the viewing chamber before you do anything. If you just grab the tissue and trephine it, you may find, oh, it was folded over in a triangular flag configuration. And what did I just trephine? I don't even know what I have. You need to inspect it, and it's actually one of the more fun things. If you get a fold, remember, there's no cells on this Descemet's membrane in that chamber. You can just take a tying forceps and move it, just reposition it to get it out. I picked up the rim and kind of tilted it diagonally, let the fluid run off. You can use Weck cells to pull fluid, and that can open things up. So inspect and be sure that you're properly configured before you ever trephine. I emphasize the vacuum trephine. The thing that no corneal surgeon has done until you do this is move one of these around. we've looked at Decimase, obviously on the inside of the eye. We've tapped to make it move. So maybe you have a sense of just how delicate it is. This is really fun. You get to touch it. And you'll find that as long as you touch it with, I find, as long as I touch it with one instrument at a time, it's almost impossible to tear it. In our own internal wet labs, we had non-surgeons who were also skeptical about this. It's so delicate. And I made them do what I just showed you, is get it totally flat, and then hand them flip it upside down, do it again, and flip it upside down, do it again. It won't tear if you do it with one instrument. For example, when I use amniotic membrane, I like to hold it with 2 forceps to bring it into position. That's probably not the way to move this tissue around, because I think it's possible to tear it in that case. So don't do that. I think one instrument, and you'll be fine. The learning curve is smoothing out the tissue. By your 3rd case, you're home free. The first 2 cases may feel just a little bit awkward to you, but by number 3, you'll feel like this is just a pleasure. And I've told many people, if you do one of these, you're going to do 20, because you're going to find a lot of reasons, a lot of other patients who will benefit from it. It's fun, it's clean. I really enjoy doing the surgery.
No, I appreciate that. That's one of the exciting things about this is, as you just mentioned, people who do one, they end up doing 2 or 3, and then they end up doing 10 or 15, and finding new ways to use it. So, and the fact that it to Dr. Tauber's point, I have played around with the tissue, and it is very difficult to damage, and I'm not used to that. So it's a different sensation. We're happy. If you haven't already done a wet lab, you can do an in-person wet lab with us at AAO or another event. Please stay in touch with us. You see right now there's a QR code on the screen. If you're interested in getting set up with Brightmem, please scan that QR code or go to our website and sign up as a provider, register as a provider. That will actually allow you to be able to get the tissue when you need it. We're always happy to answer questions around patient selection or any other questions you have. My information will be available. Dr. Tauber's is available. But overall, I want to say thank you to Dr. Tauber for a great demonstration, and to everybody who was on today. I hope it makes you feel a little more prepared to do your first BMAC case. We will send out an email shortly with a link to the recording of this session and with more information and how to register, how to order, and how to become a provider for Brightmem. We really appreciate you being here. Thank you again to Dr. Tauber and to everybody who attended. I hope you have a wonderful evening.